Looking for what's next in NHS imaging and radiology? Then don't miss RadVision South in partnership with AXREM, taking place in London on the 8th of July. This is where the UK's imaging community comes together, from NHS leaders to industry experts to tackle the real challenges: workforce pressure, reporting backlogs, AI in practice, and the future of diagnostic imaging. Expect big ideas, practical solutions, and conversations that actually matter. And of course, plenty of time to connect with peers across the sector. Places are limited, so book now at conventus.co.uk. RadVision South. Be part of the conversation shaping the future of imaging. Welcome to AXREM Insights, developing healthcare through medtech and innovation. Join Melanie Johnson and Sully Edgington as they talk with our industry leaders and experts.
Hello and welcome to AXREM Insights Condition Series. This month we are focusing on brain injury. I'm Sally Edgington and I'm here with my guest presenter Ben Tromans, a member of the AXREM Future Leaders Council, Vice Chair of the Teleradiology Working Group and Head of Client Activation and Experience for Everlight Radiology. That's quite a mouthful, Ben. Today we will have the pleasure to be speaking to Craig Rimmer, Emergency Medicine Consultant at Mersey and West Lancashire NHS Trust. So welcome, Craig, and thank you for being on our show today. Let's start by handing over to you to tell us a bit about yourself and your career so far.
Yeah, thank you, Sally. So as you've mentioned, I'm currently an emergency medicine consultant at the Mersey and West Lancashire Teaching Hospitals NHS Trust. And I suppose my career so far has been the last 5 years as a consultant here. And then prior to that, obviously through the variety of training paths, from foundation training, initially into surgical training from a core and specialty perspective, and then rerouted into emergency medicine. And again, ended up at the Mersey and West Lancashire Trust. And as of about 6 months ago, I was also the Major Trauma Trust clinical lead at our Southport site. So it's been interesting, but it obviously gives me a little bit of scope for what we're talking about today.
Thanks, Craig. And it sounds like you also have a very busy job with lots of different hats on. So you and Ben are definitely well equipped for us to have a good conversation today. So today we're focusing on something that touches lives in an instant but shapes recovery for years: acquired brain injury. Behind every statistic is a person, a family who are navigating uncertainty, hope, and the long road to rehabilitation. Our members' technologies sit quietly but powerfully behind that journey, from rapid CT and MRI that helps clinicians understand what's happening in the brain, to advanced monitoring, planning and digital tools that support ongoing care. AXREM modalities are part of the story from day one. In this episode, we'll explore how innovation is helping clinicians make faster, safer decisions, and how industry can continue to support the NHS in delivering compassionate, evidence-based care for people living with a brain injury.
Thanks, Sally. So to kick things off then, what do we think are the biggest challenges in diagnosing brain injuries today?
Yeah, thank you, Ben. I think, to be honest, probably the honest answer is I still think we're flying partially blind with this, and the reasons for that are biological and systemic in nature. I think the first issue is an issue of heterogeneity, and that's a real core problem. Because no two brain injuries are alike, it effectively means the same mechanism of injury can produce a radically different presentation, and that depends on the age of the patient, pre-existing medical conditions, and obviously the precise anatomical location of the damage to the brain, if you like. Unfortunately, I don't think our diagnostic frameworks have been really built for that level of variability. Obviously, we have the NICE guidance with regards to head injuries, and it's excellent and obviously works across a whole population spectrum. But it's hard to produce guidance that works for everyone when there's that level of variability. So I think that's core problem number one. I think there is an imaging gap. Obviously, the workhorse of the acute assessment for patients with potential brain or head injuries is the standard CT scan. And any emergency department that you walk into in England will do numbers of these a day, lots and lots. But unfortunately, whilst it is the most accessible and quickest method of imaging, it's reasonable to say that we think it misses a significant proportion of those harder to understand injuries, so the diffuse axonal injuries, microhemorrhages, and any white matter damage that MRI would catch more often and more sensitively. But the problem, and it's not just with head injuries, it's with other things such as back pain, etc. MRI isn't really available acutely in most trusts outside of major trauma centres. And obviously, an MRI is also a much more involved, much more intensive imaging modality. So, agitated or unstable patients aren't always the most suitable. So, and this is mentioned in NICE guidance around MRI versus CT. But I do think that there is a trade-off there. But as a system, and from an NHS perspective in England especially, we don't have the resources to be MRIing the patients who perhaps who would benefit from that.
And just out of interest, Craig, if if a patient is given a CT scan and potentially it misses something with a brain injury, would that delay in time have an effect on the patient? Is time critical with a brain injury?
So absolutely, we may come on to talking about AI, etc. But it's always time is brain, and it's really important. So some of the diffuse axonal injuries and the microhemorrhages are not less important, but less significant early doors with regards to managing these brain injuries. So in relation to subdural hematomas, certainly extradural hematomas, the sooner we can diagnose them, the sooner we can get these injuries managed in an appropriate way. If you're in a major trauma center, the likelihood is you have a neurosurgical center either within your building or very, very close and closely associated. But it's patients who are in trauma units whereby the likelihood is they will need discussion and transfer to these neurosurgical centers. That's where time really is of the essence, because they're not in a position to be seen immediately by neurosurgery. There's got to be an ambulance and perhaps a transfer team included in that, and therefore this is always delaying that primary management of the brain injury.
Yeah, I can think back, Craig, to my time going back about just over 20 years when I worked as a radiographer in the NHS, and I started doing CT on call as it was then, rather than being in overnight and just being on shift to man CT. And you'd be called in to do head scans. There wasn't someone there that would be able to facilitate them straight away. And I think now it's even in those non kind of trauma centres, those sort of less acute centres, you predominantly would always have CT available as a first line modality almost immediately in most cases. So do you think that perhaps where that you could sit in the future where there is a pathway to have something like MRI available, more close to hand than it is at the present? Would it follow the same path that CT's gone through?
I think it will be. I think it would be good for patients. I think, unfortunately, the infrastructure. But I suppose perhaps people have said this in the past around CT, because as you rightly alluded to, Ben, when I started, unfortunately, the best part of 20 years ago, there wasn't necessarily a radiographer in overnight. They were called in from home. Was a CT required or thought to be required, and there was often a long truncated process into obtaining approval, I suppose, for that CT to be done in the first place. So obviously we've come a long way since then, where most departments now will have a CT trained radiographer ready, waiting and ready to go. And I think the NICE guidance has helped absolutely drive some of that with the within 1 hour based on a subset of symptoms or signs, and obviously within 8 hours for others. I think MRI is the right place to go, but I think the infrastructure based around that, the training requirements, etc., and the cost, quite frankly, we have to weigh up the cost versus benefit of this. And I suspect if you speak to the radiologists, they will say, is there that much difference initially for the life-threatening or significant head injuries? Then perhaps not, but it is those diffuse axonal injuries, those ones that go on to cause longer term problems for patients that perhaps are not seen as easily on a CT, and that's where MRI could come in.
And do you think as well that would there be any difference between the challenges seen when we're talking about traumatic versus non-traumatic head injuries? So obviously think of things around stroke. Obviously, in acute stroke, MRI is identified as being an excellent modality in supporting that. But again, it's the availability. So does that need to be taken into account as well?
So absolutely, I think we'll probably end up comparing some stroke elements to various conversations within this podcast, but I do think following the stroke path with regards to imaging modalities is likely to, I think traumatic injuries are way behind, but is likely to follow that path. But again, it's the, for want of a better phrase, it's that cost versus benefit ratio. And obviously our primary, and most of our and all of our hopefully primary thoughts are, how do we treat or manage our patients the best that we can to make sure they're safe and cared for from a high quality nature. But there is that element, as I say, that MRI doesn't, it's not without its issues. It takes a lot longer to perform, and not all patients would be suitable for it. So those often with head injuries, we might have people whose GCS or conscious level is reduced, and therefore they can be agitated, they can be unconscious. If they're intubated, they need specific equipment for which they can go into an MRI scanner with. So it's that balance between availability, access, and speed, quite frankly. And also, again, if we think of the radiologist point of view, and I'm not a radiologist, so this is just me from an outside perspective, it's who's going to report them. There's anecdotally, there seems to be more availability from a CT reporting perspective than an MRI reporting perspective. Now, you might have different thoughts on that coming from Everlight, and you may have figures and facts, etc., around that. But certainly from a jobbing clinician in a trauma unit, as I am, I think that would be a barrier as well.
Yeah, I'd agree there. I think that sort of workforce element of availability, and it's well publicised in terms of the number of radiologists there are, in the UK who would be available to do this sort of work. And CT has certainly become more mainstream, hasn't it, over the last sort of 20 plus years that we've just discussed. So I think it seems logical. Actually, that's almost, whereas talking about plain film would have been before CT was invented. This is the go-to modality of choice, and therefore perhaps more people are available or able to report those scans. As soon as you start looking at MR, are you therefore having to look at people who are perhaps formal neuroradiology specialists, and again, smaller pool to find from, therefore less availability. And also I think the element around the workforce, looking at the availability of radiographers in terms of where scans can be acquired overnight. As you said, you work in a centre where it's a it's not a trauma centre, it's a relatively small hospital. So what does that look like compared to a trauma centre? You might have multiple scanners, multiple radiographers, again, being able to deal with that when you're talking about, minutes can make a difference to a successful patient outcome or not.
Yeah, and I think, Ben, you've just summarised. I wrote two things down as my summary and kind of takeaways from that is time is brain and working within parameters of expertise and resources that are available. So, yeah, I totally agree with you. Moving the conversation along a little bit now, how do you think AI is transforming brain scan interpretation? And I'll let you start, Craig, if that's okay.
So I think, I suppose I didn't mention this at the beginning, but I'm also the Chief Clinical Information Officer for MWL. So AI is something that is obviously front and center with my day-to-day work. So there's genuine encouragement here. Always got to be mindful, and I'll probably come to that in a short while. But realistically, and this is what I was talking about earlier in relation to stroke, evidence is now landing in real world NHS data. Before, it was a lot of research papers, which is absolutely great, brilliant, should be encouraged, and obviously should continue. But we've had AI tools in relation to stroke for a number of years now, and I think, as per the last data, I think there were 99 out of 107 English stroke units who have deployed some form of AI tool for their CT head interpretation. And NHS England analysed this, and it was published in late 2025. And their analysis of it was that AI assisted interpretation of CT scans can triple stroke recovery rates by compressing that decision to treatment time. So bringing that down significantly. And whilst we can't necessarily compare the traumatic brain injuries with a stroke because the management of them is significantly different, there is still something that resonates there around that ability to diagnose quickly, and therefore the management can start. The thing is, with technology, it takes, to a degree, it takes the person out of the initial element. It's not actually, the headline sounds very good, triple stroke recovery rates, but the technology just analyzes the scans in real time, flags those large vessel occlusions, and obviously pushes an alert to the clinical team within minutes. So it's not waiting on someone to interpret it, whether that's an in-house radiologist, an external radiologist, it's helping. And obviously, if you've not got neuroradiology on site, which most people outside of London and probably the major city hospitals don't, then that's a really transformative capability. Bringing it back to traumatic brain injury, I suppose specifically, AI is beginning to assist in some those injuries. So automated hematoma detection and volume quantification. So the reason why this is really important, certainly in the area that I work in, because the Liverpool head injury tomography score, the HIT score, was devised at the local regional neurosurgical centre, and part of that relies on contusions and hematomas and volume of those hematomas, and that allows us to effectively categorize these patients into what management they need. Do we need to be contacting the neurosurgical teams or not? Now, that's really powerful, because if we don't need to be contacting them, then that means the neurosurgical team can be focusing on the patients who they do need to look after and who they do need to be contacted about and move those forward those patients forward. So it's really, really useful in that regard. I suppose the caveat with all of this, and we've got to make this clear, is obviously NICE's position. I think it's under DG 57. These tools are in evidence generation phase. Now there's a huge 10-year NHS plan, analog to digital. It's all in there, and this is the way we're heading. And we've just got to be mindful that these tools support clinician decision making. They don't replace it. And we've just got to be mindful that any trust deploying them, or any companies or whatever it might be, whether it's industry, whether it's NHS, we just need to make sure that that risk is, I suppose, identified and made explicit.
Yeah, I completely agree there, Craig. Just for sort of full disclosure, I worked for a couple of years in the AI industry before my current role, so I've got a little bit of an insight into the sort of the flip side of the coin. And certainly, I think the implementation and adoption and sort of monitoring of these products is absolutely essential to them being used successfully and appropriately. I think the risk is if you just sort of turn an algorithm on and let it run and it's spitting out reports and clinical information, there's a real risk there that can be misinterpreted or just not used at all or not trusted. So I think there's all of us in the medical imaging arena who are involved and have a sort of a responsibility to really focus on that. But one thing I'd seen, I'm not seeing this in person, but I've read about it, is that there's some AI tools where it's actually got that sort of end-to-end communication loop built in as well. So the AI tool would identify a potential finding, and once that is identified and triggered, it would then notify, for example, your trauma lead, your neuroradiologist, your neurosurgeon. So they are warned at the earliest opportunity that there might be a patient that requires their support and intervention, which is obviously time critical, as we spoke about in the previous question. So for me, it's going to be, what cases is something like that going to be good? If you've got a situation where you have a neuroradiologist sitting there in the scanner reviewing in real time, perhaps the AI has a lesser impact on that particular patient pathway for that individual. However, in a setting perhaps as like yourselves, where you don't have neuroradiology available directly, the support that would give to perhaps the general radiologist who's reporting that case, then to be able to identify, should this patient be referred for neuroradiological and neurosurgical review in a very, very quick time frame, could be immensely valuable to that patient, who would then be actually transferred into your regional neurosurgical network, perhaps quicker than it might have been otherwise. And obviously that's a huge plus for that individual.
Absolutely, and I think because of how AI tools are developed, the more information, the more data we can give the AI tool, the more reliable and robust they will hopefully become. We know that AI, moving slightly away from brain injuries, I suppose, but we know that there are AI tools for other radiology modalities, so X-ray, especially around fracture detection and chest X-rays, that are already in play. And I think it's, as you say, that regulation needs to be tight, and each individual organization should be going through their clinical safety workflows and making sure that from a governance perspective, everyone's happy, because each organization will have different problems or different nuance to this, and therefore there's not necessarily a one size fits all with regards to the governance and the clinical safety case reports and the clinical safety documentation. But the tools themselves will be based on their error rate, etc. And that's where, certainly from a radiology perspective, we just need to be mindful and making sure that everyone has oversight of that, if indeed there are any errors with the tools. And let's face it, humans are prone to, not errors per se, it's not, no one does it intentionally, but we will all miss things. If you say you're right 100% of the time, then I think it's probably fair to say that you're lying.
Absolutely,
yeah.
Indeed, and I think AI, again, that's what I've certainly found when I've worked on projects implementing AI in the past. is that you have to factor in that kind of that ongoing review and audit, exactly as you do when you're providing a clinical reporting service. As you said, humans make mistakes. ED doctors will make mistakes, radiologists will make mistakes. The important thing is just to make sure that those mistakes are, I guess, in the context of someone's, what's expected to be the sort of their performance professionally and their clinical skills, but also that there's processes there to catch and identify those mistakes and to alert people so that they can be remedied, but also to be able to learn from them. And I think to go in and use AI almost blindly without having a similar kind of overarching governance awareness is very risky. But I think that's probably something that as people are using these products, trialing them, piloting them, etc., is something they're having to kind of get their head around, and if it's become part of like the standard process. So that's interesting.
Yeah, and I also think in relation to the lessons learned, it's the good things as well, the positives of what's working. And I think where we see good practice, then I'd love to see more upscaling of AI. And I think that's where some of our members have struggled, especially in the radiology community. Upscaling is quite patchy. And obviously, we don't want to lose these amazing technologies in the UK. And we want to make the UK a good place to come and do business. And I find that I've been approached by AI companies in the past that are looking to bring an algorithm here, and they sort of find it such a difficult market to navigate that they decide not to stay or not to come in the first place. And that would be a real shame if there's patients that are benefiting from AI solutions in other countries, and obviously, for the good of patients and for speed and accuracy, and then our patients here aren't. So I just wanted to kind of say that I think lessons learned absolutely with the negatives, but also with the positives. And I feel like that's where there's lots of trusts throughout the country, and I think maybe sharing of best practice isn't always as good as it could be between trusts, because they can work quite individually as well.
That's why I think things like sort of the way that stroke networks have developed over time and obviously focused regionally. There's a lot you can read about them and how successful they've been and the benefits they've had to patients, because things have been learned about in the past. So for example, Craig, you mentioned you have a regional neurological centre where you refer patients into if you need to, and there'll be designated pathways, won't there, in terms of how that can work really quickly, really slickly. And I'm sure there's times where perhaps it doesn't work quite as well as they've been designed to, but the fact that they're there, that's come through learnings in the past about patients needing to be referred to the right specialties in the right time frame. And this is where things like AI tools have that benefit, because they're always on, not waiting for a human to be available to look at a CT scan or to make a phone call, for example. The AI is always on and can perhaps help plug that gap in parallel to the clinical expertise of a human doctor.
Yeah, and you make a really good point, Ben, around the AI always being on. So it's that, for me, it's that element of it can flag significant issues, in this case, injuries, but obviously from a stroke perspective, it can flag to a reporting radiologist who may have 20 in the queue that actually there might be a critical finding on this report, therefore you need to move that up in your prioritize, or consider moving it up in your prioritization of reporting schedule. I think also we kind of mentioned, I think Sally, you mentioned around I suppose how we upscale, and I think the ICS model, I do think creates new opportunity. Well, I say new opportunities have been in place for a while now, but it does create an opportunity, because we've seen it, and again with digital hat on, we've seen it in a number of ICSs around things like ambient voice technology, where there has been shall we say, a mass procurement, and that's been an ICS mandate to go out to all of the trusts within that ICS. And I think if that's negotiated at a kind of population level, a commission pathway level, then rather than each trust individually buying or procuring a system, then I think that helps the types of suppliers that you mentioned to get a foot in the door, to understand, get those pilot phases done, and then an understanding of what's gained, what the benefits are, what the benefit realization is from that, because we can't hide from the fact that currently the NHS is financially challenged, and from that perspective we need to be making good long-term decisions wherever we possibly can, and that mass scale procurement is one way of doing that.
Yeah, absolutely. So I think if we move on to our next question, because I know that was a good discussion on AI in brain imaging. How do we think industry and the NHS can collaborate to improve outcomes? So I think there's a lot of overlap with some of what we've just been discussing, actually. But yeah, perhaps back to you on that, Craig.
Yes. So I suppose I'll start with what the point I've just raised. I think the ICS model really helps create new opportunities here, because if we're honest, I think there's always been a challenged relationship between the NHS and industry or commercial partners, and I don't think that's due to anyone in particular, as in any side of that. It's just that the NHS is such a huge, well, it's a behemoth of an organisation. It's huge, isn't it? That often procurement can be truncated. Pilots can get stuck in, I suppose, what I would call proof of concept purgatory. Effectively, what we were just saying there's then data sharing agreements, and data is a huge issue when trying to look at how we procure systems certainly on a huge scale. And obviously information governance absolutely is vital and really important, but often those data sharing agreements become problematic when dealing with numerous trusts, because there isn't just a one size fits all. And I wonder, and I don't know, because it's not from my perspective as such, because I don't tend to deal with this, but I wonder whether there's a cultural wariness between both the NHS and industry, just because of the past and the things that haven't gone as well as we would like. But I think that probably comes back to Sally's point there in relation to what about the ones that have gone well, and we don't really take those into account, because we're all critical of ourselves when things don't go well, but actually when things go well we just expect that as the norm, when actually that's not necessarily the case. With my multiple hats on, sometimes products are designed for what I would call idealized workflows. So on a Tuesday morning when everywhere's fully staffed, this is the process, this is the workflow, versus a Saturday night, midnight chaos of an emergency department, and it's all kicking off, and it's all problematic. So those workflows are very, very different, and that sometimes leads to a bit of a challenge there.
Yeah, some really good points there, Craig. I agree with those. I think the one area that, and this is, speaking from my own experience of obviously working in sort of companies that have been focused on sort of the technology IT side of medical imaging, certainly around the implementation of the drive with technology and innovation in things like teleradiology services and AI products. Absolutely, that's something which I think industry can really help accelerate. And you just look at even at things like CT scanners, how they've developed over the last 20 years, how fast they are, the power they have, the image interpretation, the image manipulation that you can do very, very quickly compared to sort of previous iterations. It's all really good in terms of improving sort of the time that a diagnosis can be established, and therefore the time that a patient can be treated. And when we talk about brain injuries, go back to the whole the time is tissue mantra. So I think there's I think where industry does have sort of a big role to play as well, is around that the interoperability between sort of different systems, different pathways, technical integrations, how a clinical workflow in a hospital can align with a technical and operational workflow that an industry partner would have to provide a service or a product. For these things to work seamlessly, there's got to be minimal friction between all those different elements. And I think when you get NHS and industry, there's always that risk that everyone's sort of working at different paces or working slightly different ways. So I think the ones that are successful are the ones where those gaps can be sort of honed down, and it's really sort of slick and smooth between them. And I'm sure you've seen that work well, and perhaps not work so well in your time as well, with services and products that you've used in your department.
Yeah, absolutely. And I think where collaboration works really well, it tends to, in my opinion and from experience, it tends to share a few common features. And one of those is that co-design from a very early stage. Now, ideally, that would be co-design of product development. So I suppose what I'm getting at there is clinicians embedded in that product's development, whatever it might be. But even if we, for argument's sake, we take Everlight as an example, okay, we're not going to be getting involved in the product development per se, but it's about that process, how it works, how the workflow is in each individual hospital. And I think that's something that, from my experience, worked very well from our end. It was that we were involved early, and we did I think it went in very well from the Everlight perspective. But I do think the other kind of general elements are data access. I know I keep coming back to data, but it's really, really important that we protect data, obviously adherence to the information governance principles, etc., and making sure that we've got that robust governance in place. But some of the friction, as we call it, as you say, would be due to how much access to data do we get, etc. And I think it's just being mindful of that. And I was reading part of the HSJ a few days ago, and it was really interesting to see, and I don't think anyone is quite there with this yet, but it was interesting to see how any future digital projects may have their contracts tied to patient outcomes and, I suppose, benefits realization, either financially or from a patient perspective, and whether the shared outcome metrics are having those contracts tied to specific elements rather than deployment volume. So it's going to be hitting, for argument's sake, 500 clinicians or whatever it might be, or X amount of thousand patients, rather than deployment volume. Do we look at how those contracts are drawn up, really, and understanding that? But it's really difficult because there has to be something in this for everyone. Otherwise, why would you spend a lot of time and money and effort bringing a product to market if there's not going to be a financial benefit from it? Again, anyone who says, who argues against that, we just need to have a think and understand what the real world is like.
Absolutely. And I think there's a strong case to say, and you look outside medical imaging, you look at all, technology innovation is typically driven by, industry, or whatever that might be. But, sometimes that's for purely commercial gain, other it is because, technological advancement or academia perhaps, but that doesn't just tend to happen on its own, because you do need to, you need to take a risk, whether you're setting up a business, whether you're designing a product. There needs to be investment, and there's risk, and it might come off, and that company or that individual does well, but also it might fail, and they lose their investment. So that's where I think that industry public sector partnership can work really well. And I think the word you use, collaboration, certainly the approach I've always tried to take in the projects I've been involved with in my career, and the way I think what has worked best is when it is more of a collaboration and is viewed from both sides as a partnership, rather than purely that transactional NHS industry, kind of commercial, you're paying for a unit of activity or for a number of installations of a product or whatever it might be, or syringes you're buying, etc. It is actually more a service, a product is being procured, but actually to make best use of that, to get the best benefit to the service, the best value for money, return on that investment, and then most importantly, the best outcome for the service's patients is if actually everyone's kind of pushing in the same direction, and working together in that way. So I think that'd be my sort of key view on that.
I think that, with companies' margins being a lot tighter than they used to be, I do believe that, especially in our diagnostic imaging area, that the companies are in it because they want to do what's right by the patient as well. And certainly I know that's very much the focus of the people that are involved with AXREM. But I think moving the questions along, what do you think the NHS now needs most right now to improve brain injury care?
So, I mean, this is a very wide-ranging question, but I suppose if I was trying to distill it to a couple of things, I would start with I mentioned before around the imaging infrastructure. So absolutely, CT is the workhorse, but realistically, when we look at the pathophysiology around brain injuries, MRI is the key, and we know that availability out of hours is limited across much of the country, and I think this isn't a technology problem; it's a funding and a staffing problem, with theoretically a straightforward but very expensive solution. That would require national guidance, or national guidance changes, that would require national buy-in, and I don't think that's going to happen any time soon. But as we've alluded to, we probably, if we'd have been sat here 20 years ago, we'd have probably said that CT wasn't going to move where it has done. So I think we need to keep our minds open and our options open. Obviously, I suppose alongside that is the workforce, and I think, Ben, you mentioned this a little earlier. It's that element of, we have a shortage of radiologists in general, never mind neuroradiologists. But also, if we think of these injuries and the patient and the knock-on consequences and effects, it's not just that diagnosis. If we're relating it to brain injury care, it's also the neuropsychologist to deal with the impact from a psychology perspective, and the specialist rehabilitation clinicians from a head injury perspective, all of which I think are really in their infancy. There are pockets of good practice around the country, but again, outside of major trauma centres, I can only speak for us, we would refer our patients into our local, it is the regional, but local neurosurgical centre for these patients to be seen. But that service is probably run off a handful of people at most for a whole region. So again, if we're thinking about how to improve brain injury care, I think acute phase is improving, mainly because of the NICE guidance, the fact that we have good, easy access to CT scans, and it's that post-acute phase that I think remains fragmented and probably postcode dependent. We don't like, obviously, postcode lotteries in any shape or form when it comes to delivering care for our patients. But what we don't want is I'm going to pick two random places, but a patient in Leeds shouldn't necessarily receive a different rehabilitation offer to a patient in Cornwall. But I would imagine right now they probably do, and that's replicated across the country.
And I imagine we see that. I was going to say, I imagine we see that across not just in brain injuries, but across other areas of healthcare as well, don't we?
Absolutely. It will be not everywhere, but it will be in a lot of areas, and that's where obviously we're hoping the 10-year NHS plan will start to bring some of that and reduce some of that differentials in management of patients. The other thing, and again, I don't know how feasible this would be. But if we look at our Scandinavian friends and colleagues, they have a lot of national data on from a health perspective because they have a national registry. And we have, from a trauma perspective, we have our National Major Trauma Registry, which it collates all the information around any major trauma injury, so not just head injuries, but other injuries outside of that. But whether a national brain injury registry would be a reasonable thing to do, because we don't really have that comprehensive longitudinal outcome data at a population level that we can look at to try and improve, and how we can systematically measure and get some metrics for improving our care, because we're all saying, because it's logical, that time is brain. So the earlier we diagnose, the earlier we manage, will lead to a better outcome, and probably does. And most of the research backs that up. But a national brain injury registry would be really, really useful.
Yeah. And I think you've almost answered our final question there, Craig. We just sort of segued into it very nicely there. Around, so how do we think early imaging can impact long-term recovery outcomes? And I think you talked about that in terms of, actually, at the moment we perhaps don't have that total kind of umbrella view of those longer term outcomes for patients with traumatic and non-traumatic brain injuries. But I think it's very, but regionally and locally, it is, it's very well recognised, isn't the fact that access to early imaging does lead to better patient outcomes. But again, is there that bit in the middle where perhaps there is that variance depending on where you live? Have you gone straight to the major trauma or the neuro centre, or have you gone to one of the local hospitals in the area that feeds into them, for etc., or you live in a different part of the country?
Absolutely, and I think again, it's those faster scan to decision times will absolutely translate directly into better functional outcomes, and we've seen that with stroke. We know from the evidence that's been presented that's the case with head injuries as well, if managed appropriately. But it's those lower rates of severe disability, and obviously, again, when we bring this all back, it's about quality patient care and ideally getting people back as functionally able as we can. Whilst early imaging does enable faster treatment decisions, there are other I suppose knock-on effects of that as well, because it can guide the likes of rehab planning. Because if you know the precise distribution of the injury, obviously you can then get the rehabilitation teams and therapy teams to work on that from an early intervention perspective. I suppose it's also identifying patients that are at risk of any delayed deterioration. So subdural hematomas and contusions in traumatic brain injuries are two of those. They can evolve over 24, 72 hours. And knowing that allows you to hopefully predict a little bit. But I think probably the one that's not really spoken about as much, and it really matters for the patient and for the families and loved ones of the patients, is those supporting those prognostic conversations. Because when, and as ED consultants, myself and my colleagues and everyone who works around us, we have to have these conversations on a fairly regular basis. And they're difficult. Of course they are, because it's upsetting for the family. Often it's unexpected. It's not something that they've been expecting for this to happen. But actually, if you can have some element of prognostication from the imaging, then it allows you to have that conversation in a much more planned and prepared way, and allows that family to understand what's to come and what's to happen. And I think that's a really, really important part of this that sometimes gets overlooked.
The risk is then people just turn to Dr. Google or its equivalent and aren't necessarily guided by those with the expertise around them. But thank you for that, Craig. That was really insightful.
Great, thanks, Craig. This is where we change up the podcast, Craig, and we ask our quirky question. So the quirky question today is, if you could swap brains with any historical figure for a day, who would it be and why?
Oof, now that's a challenge. Probably the couple of people that spring to mind would be either Richard Feynman or Leonardo da Vinci. But I'll probably go with da Vinci, because from what I read, obviously, it's from what we all read and what we understand from him. It wasn't that he was smart. So he was obviously very smart, but he just seemed to be quite structurally different in how he connected things. So he'd go from dissecting corpses at night to understand the musculature of the human body, to then designing a flying machine in the morning, and then painting something along the Last Supper in the afternoon. And I think to all of us, they seem separate, obviously very, very different things to do. And but for him, if I don't know whether anyone's read anything about him, but in his notebooks, they weren't separate projects. They were linked. They were all the same project. So understanding how someone's brain like that works, where there's a seamless transition between art, which I'm not very good at. If I add, I'm terrible at art, but science, observation, imagination, I think it would be very, very interesting. His brain is probably most unlike mine, and therefore I think it's worthwhile visiting that.
And what a great answer. And I was going to say no one would ever want to switch my brain with them, because it's scary. It's scary the pace that my brain turns over and what I come up with next. So no, that was a really great answer. But it's been great to get to know you more, Craig, and we really appreciate your time and get some further insights into brain injuries. A big thank you to Craig for joining us, and to Ben Tromans for guest presenting alongside me. And thank you to all of our listeners.
If you've enjoyed today's podcast, don't forget to hit subscribe, or feel free to share the podcast with friends.
Join AXREM at our external stakeholder conference, Imaging Tomorrow, Innovation, Insight, Impact, on Wednesday the 14th of October at the Royal Society of Medicine. From NHS policy and community diagnostics to AI in practice, sustainability, procurement and cybersecurity, this is where big ideas meet real-world impact. Hear the latest thinking, explore the challenges and connect with leaders from across the NHS and MedTech. If you care about the future of diagnostics, this is the room to be in. Secure your place now at www.axrem.org.uk/event/AXREM-external-stakeholder-conference, or click the link in the show notes.